Hello.
question.
Yeah, what's up?
Okay, so what is the best way to study? Like if we go over, you're gonna go over the exam today. What is the best what takeaway from what you're gonna tell us? Like, do we know everything you say, highlights, or are you gonna explain it?
So, we're gonna do my plan for our review session is I wanted to kind of open it up to see what you guys were wanting to get away from this. So, things that you're struggling with, concepts that when in class, um, you guys were, it was kind of hard to understand, or you want me to clarify some points. We can kind of go through like those individual things. But I really want us to do, I have a couple of Kahoot games pulled up that is going to just do like practice questions. And it'll be formatted pretty similarly to the kind of questions, not the exact questions, obviously, but like very similar questions to what you're going to see on your exam. So, it'll give you an idea of how it's going to be worded and what you're going to want to like take away from each topic, right? So, anytime you're taking a nursing exam, it's not just what is the definition of this? It's this is what's happening to your patient. What are you going to do as the bedside nurse, right? Critical thinking type stuff. So that was kind of how I wanted to outline today. Professor McBride said for these sessions we usually go about an hour. I have a little bit of time after that if anybody needs extra help or clarification on something, we can go over some more things. So
I
um,
would definitely like to go over like week one stuff since you weren't here. And we had to join Dr. Roberts, and we
okay.
pretty much spent that entire time introducing ourselves. And I believe we got to leave early because we weren't in her class.
Okay. All right.
So I don't feel like there was a lot that we went over.
Let me pull up my PowerPoint that I had made and see the important things that I'm going to want you guys to study for your exam from that. Let me just get that PowerPoint up. So, this PowerPoint week one was focused a lot on like caring for different types of cultural differences, um, promoting like autonomy for your patients. It goes over a lot of like how we reduce health disparities, right? So that was kind of like what we had talked about with our first discussion post is like, what are ways that nurses, as bedside nurses, how can we make this healthcare more attainable for patients in a different type of population who may not have equal access to healthcare? Um, I believe I have, let me see. So I have one of the Kahoots that we're going to do is titled Exam One Review. So it's going to go over like week one through three content. So there should be some week one stuff in there. And if we encounter it, we can talk about it a little bit more in detail. The biggest part of week one that I think you guys should focus on would be cultural competency, um, knowing the internal structures, like that is more of the anatomy. Like first week was a lot of anatomy stuff. So, knowing your internal structures and like where does fertilization occur, the cycle, the reproductive cycle, the pelvis, like we kind of talked about that yesterday in class, like what is your ideal pelvis shape for birth, which is your gynecoid, right? So, kind of knowing that, knowing which pelvis shapes are not um, suitable for delivery, but definitely review like your cultural competence, your basic anatomy, and your menstrual cycle. I think those are the biggest things to know from week one. But, like, as you guys know, our exams are comprehensive, right? So, there's only a certain amount of questions that we're going to ask. And um, so as long as you hit like the big points from each week, um, that should help you a lot with it too. Okay. What other things do you guys need more clarification on?
So the questions we'll go over today will be all of what we need to know.
No, we're just basically doing review. So like this is going to be helpful in kind of understanding like how the questions are going to be formatted, but obviously like we're not going to have every single question from the exam like reviewed today, but we're going to go over a lot of things and a lot of points from the last 3 weeks, like the main points that'll be good for you guys to kind of focus on when you're studying. So if you guys want, let's go ahead and start with this Kahoot review, which I think these are cool because um, we can kind of talk about an answer after you guys submit them. If like a lot of you missed something, we can go into it in a little bit more detail. Okay. So we're going to start with a Kahoot that is going over like week 2 stuff, which is the fetal development, genetics, anatomy and physiology, the nutrition, that kind of stuff, which should hopefully also tie in a little bit of information from um, week 1. Okay, so let's see.
Sorry, fetal genetics, anatomy, and what was the third thing you said?
It's going to be nutrition. So fetal development, genetics, anatomy, nutrition, which you can see it here too. All right. Have you guys used Kahoot before? So it's going to give you a little code on your screen. Use your phone for it, and it'll prompt you the questions. And then you guys will have to pick from the answer that you think is the most correct. And then once everybody has submitted an answer, it'll pull up, it's anonymous, so we're not going to see who individually selected what, but you'll be able to see um, if your answer was correct or not. And then if like a lot of people missed it or a couple people missed it, we'll go ahead and like review that question. So let's get this one going.
I may or may not be in my car, so I won't be able to play it, but I'll listen.
Okay, that's fine. Yeah, just be safe. So if you guys put this game pin in, if you go to Kahoot, www.kahootit, and then you put this game pin in, and then you'll be able to join the game. All right. Are you having an okay time finding it, Yvonne?
I was I'm on the app, but it keeps a asking me all these random things like how old am I?
Oh, it's like making you have it create an account or something.
Yeah, it didn't go straight to
Just
plug in a.
do you
Oh,
want
here it is. I found it.
it? Okay.
It still made me sick. Yeah, sorry.
No,
Okay,
you're fine.
I'm ready.
All right, no worries. All right, perfect. Let's go ahead and get started then. Okay, so I think that these have come with a time limit on them, which we can kind of change towards the if we need to, like in the next couple of games. But yeah, this one, the term that refers to the developing baby from day 15 until 8 weeks after conception is an embryo. Okay, so this one was just a little bit more terminology based. All right, but it's good because this stuff is content from week one. All right, if you guys are ready, let's do the next one. Awesome. So the term that refers to the developing baby from 9 weeks of gestation to the end of pregnancy is your fetus, correct? Yes. So this is your ductus arteriosus. So as we know, babies are not actively breathing in utero. The fluid is going to have to bypass the lungs. So the mechanism of that is the ductus arteriosus. So yes, that is correct. Another important one that you guys should probably like look up and know is your foramen ovale. We talked about that a little bit in week two. That has more to do with your circulatory system in the fetal heart. So I would just definitely know the differences between your ductus arteriosus and your foramen ovale, just for studying purposes. All right, let's go ahead and move on. So your third week is when your fetal heart begins pumping blood, which is like kind of shocking how early it is. But um, yes, your third week is whenever fetal blood, your heart begins pumping blood in the fetus. Yep, so it contains two arteries and one vein. So that is really important to know. You guys should definitely be able to tell us that, okay? Um, two arteries and one vein in your umbilical cord. Yep, so your amniotic membranes, your amniotic fluid is what's surrounding the baby. And then it has the layers listed here for you. So yeah, just your amniotic membranes. Yep, your placenta. This is worded very interestingly, but basically, your placenta is comprised of different lobes. We didn't go into that in super detail during class because we weren't identifying each individual ones, but your placenta, I would definitely know the purpose of a placenta in providing oxygen and removing fetal waste. Okay, just definitely know your overall, the overall functions of these organs in fetal development. Yep, your trisomy. So, what's the normal amount of chromosomes that we have?
26.
Yes. So we have an extra one here. So that would result in your trisomies, which is what the ones that we went over mostly in class were your trisomy 13, 18, and 21, right? Your Down syndrome and your Turner syndrome. So knowing those syndromes and like how that baby is going to present, like the anatomy differences, what they're going to look like, that's important. Yep. Your basic physical units of inheritance that are passed to your offsprings are your genes. You guys all got that right. So that's awesome. So this one is autosomal recessive. So when we're looking at this question, it's a genetic disorder in which both genes of a pair must be abnormal for the disorder to be expressed. For it to be recessive, that means that both of the genes from the parents have to contain the disorder in order for the child to physically present it, right? So this is different from dominant disorders because usually in dominant disorders, only one of the parents need to have the gene for it to be expressed in the child. So if you're seeing that both genes of a pair are abnormal, that is hinting that it could be autosomal recessive. Yes, so this is your parity. So this kind of goes back to GTPAL. Your G's and P's is your gravity and your parity. Your gravity is how many times a woman has been pregnant. And that does not necessarily mean full-term gestation. That could include ectopic pregnancies, that could include miscarriages. chemical pregnancies, those kind of things would all be considered a pregnancy and would fall under your gravity. Your parity is the number of pregnancies in which the fetus is delivered after reaching 20 weeks gestation. Okay, so definitely know your GTPAL mnemonic and what each of that means, because I could foresee like there being a question like a mom comes into OB who has 3 living children at home, has a history of a miscarriage, and is currently pregnant with twins. What is her G's and P's? What is her GTPAL? So being able to choose, okay, like she has a miscarriage, that still counts as a pregnancy, right? Having twins only counts as one pregnancy. And then she has 3 living children at home. So her G's would be 5. Her P's would be 3 because she only has 3 living children. Okay. So, and then if you're doing the whole mnemonic, then obviously your miscarriage would fall under A for a spontaneous abortion. This is quickening. So, your ballottement, that is if the baby's head is applied on the cervix or not. So if a baby's head is ballottable, that means you can like kind of like move it up and down if you're checking her vaginally. Like the baby's head is not firmly engaged onto the cervix. Quickening are those light movements that the pregnant woman feels, which can be early as 18 to 20 weeks gestation. So this is that GTPAL that we had just kind of talked about. So the GPAL is just missing your term. So if you're going through the entire obstetric history, which you would see on a patient's prenatal, it goes through gravidity, term, preterm, abortions, and living. That's how it would be kind of broken up. Yes, so let's go through this one together because I know most of you guys got it, but I think this is going to be really important, especially for your exam. So this woman comes in, it's her 4th pregnancy. Her first ended at 12 weeks. That's a delivery that's earlier than 20 weeks gestation. Okay, so that would be considered a spontaneous abortion, elective abortion, whatever the case may be. So that is going to go under your A category. That pregnancy will be under your A. Second delivery, so her second pregnancy, delivered at 39 weeks. So that's a full term gestation. So that would be under your living, which would be your L. And then your third pregnancy was at 36 weeks, which is also over 20 weeks. And it was a term baby, viable baby. So that would go under L as well. So she is in her 4th pregnancy. So her gravidity is 4. She's had one term. Oh, that's because the one delivered at 36 weeks. So that can be a little bit tricky. But if the one was 39 weeks, that's full term. Parity would be 1, so preterm, would be 1, so that would be her 36-week delivery. Abortion would be 1 because that was her 12-week miscarriage. And then her living would be 2 because she currently has 2 living children. Okay. So then you have the 4-1-1-1-2. Okay, so that is how you would do it with it all completely broken out like that. Yep, you guys all got that right. The vegetables, whole fruits, grains, low fat, dairy, and protein. I don't really know what the 10% of kilocalories or the fat or anything like that is. So, yep, you guys all got that. Yep. After 37 weeks gestation is considered a full-term infant. Preterm would be anything before 37 weeks. So 37 weeks is kind of your definition for like after that is full term, before that would be your preterm. Post term would be anything after 40 weeks.
If they, so when I was at clinical, they had a mom that she was a day, like 1 day short of being full term, so it made her preterm.
Yeah.
That it goes by days, doesn't it? Like not just weeks. It goes by weeks and days.
It goes by both, right? So like for your guys' purposes, we're focusing mainly on just like your weeks of gestation. But like on the floor, if I had a patient that came in who's 36 weeks and 6 days pregnant, she's considered preterm.
Okay.
And the reason we do that is because so whenever you're doing dating ultrasounds, right, which kind of go back even as early as like if a mom is 10 weeks pregnant, we're doing a dating ultrasound on her to make sure that her dates line up with when she was saying her last period was. Those ultrasound datings can be like off by as much to I think it's 5 days. They don't change your due date unless you're over like there's over a 5 day difference between the ultrasound and your last menstrual period. So on the floor, that's why we kind of go by days because you could have a 36-week and 6 day infant that is delivered, and when you do their gestational age, their dating, that kid could age to be 37 weeks and some change because the dates were just a little bit different. But then also vice versa, you could have a 36-weeker who dates at 35 weeks or less because maybe it was an IUGR pregnancy or there's always a little bit of discrepancy with the dating because you can't like it's very hard to be exactly accurate, which is how pregnancy progresses and how the babies are growing. So that's where we go by the days too. But for your guys' purposes, I would just definitely know like if you have a 37-week or older, that's term baby. Anything under 37 weeks would be preterm. And like also some hospitals, like most of the time it is 37 weeks. But certain hospitals are a little bit stricter about like who delivers there because like at my hospital, we're a small LDRP. So we don't deliver anyone that's under 35 weeks because we don't have the NICU team or like the staffing available. So some facilities are a little bit stricter about their definition of preterm versus post-term deliveries. So this one was the measurement performed beginning in the second trimester as an indicator of fetal growth, and that would be the fundal height, correct? So we're measuring how the mom's belly is growing at each appointment. So this one is more of like a definition. So your rapid, unpredictable changes in mood are like that are likely due to hormone changes would be your emotional lability. We didn't go over these definitions too much. Um, your postpartum depression can also be those rapid, unpredictable changes in moods because of hormone changes. So I completely understand why you guys picked that one. Um, Ambivalence. Let me see what I have in my PowerPoint. So I believe your ambivalence, when we were talking about it in our class, was the stages of acceptance for the pregnancy. I believe that's where we were. I'll go back to this in the PowerPoint because I can't pull it up on my phone right now because I have it on my computer. But I believe your ambivalence is one of the stages of like parents coping with the idea of the pregnancy. We'll go back through that. But for the purposes of this, because we were going over week one, the answer is emotional lability, which is something that a pregnant woman will experience. Typically, in the first trimester is when you see it the most, but it can last throughout the entire pregnancy where the mom is just having like these crazy moods and hormone mood swings because of her increase in progesterone and estrogen. Yep, so this would be June 17th, 2021. I would definitely make note that you guys are gonna need to know Nagiel's rule on your exam. Okay. So know that formula, right? So it's adding a year to the last menstrual period, subtracting your 3 months, and then you add 7 days. Okay. So I definitely know how to do that for the test. So this would be your hyperemesis gravidarum. And the difference between this and just your regular morning sickness is if you're seeing words like severe, persistent, that is ultimately causing this mom to have adverse side effects from it, that is more of the hyperemesis gravidarum. Whereas like morning sickness, if they wake up and they throw up once and then it's done for the whole day, they're not going to have weight loss. They're not really going to lose that much of their hydration or get thrown into any type of electrolyte imbalances. Hyperemesis gravidarum is a lot more serious, and some women will actually have to be hospitalized for it and get nutrition IV or even like just like continuous fluids IV with like around the clock antiemetics. It can be pretty bad sometimes. So yeah, if you see these words severe, persistent, um, that would be your hyperemesis gravidarum, not just your morning sickness. Yep, so this would be true. A BMI of 18.5 to 24.5 would be considered normal. So this is pica. Um, and we know that it's that instead of food cravings, because if you're craving non-food substances and you're eating like excessive amounts of food with that have like a certain nutritional value, that means that your body is trying to compensate for something that it's lacking. So like these are women who might like eat paper or who are like craving paper or who are wanting to eat like ice chips. You know, they're eating stuff that's super weird that's not actually like going to provide them with nutrition, but it's because they might be anemic, right? People that have severe anemia are often the ones that are trying to eat ice chips all the time. Um, and it's not actively like helping that condition at all. It's just something that their body is craving because they're lacking something else in their body. So if you're seeing this weird like non-food substances, that would be your pica. So this would be your kick counts. Um, this is your daily assessment. So that's something that moms are going to be doing because we're not seeing them every single day in the office or in clinic. So this is something that we're telling moms to be doing on their own every single day. So what are some things that we educate patients on, like how to do fetal kick counts? Like what are we supposed to be telling the patients to look for or what to do?
Well, I know you want there to be 10 in a 2 hour span.
Yep, definitely. Yep, you got it. So 10 in a 2 hour span. We want them to do them at the same time every day, ideally. And if they don't have adequate fetal movement, we're telling them, okay, drink a huge big thing of water, lay on your left hand side. If this doesn't correct and you don't feel movement within the next half hour to an hour, you need to come in. And then whenever they come in for decreased fetal movement, then we start doing like the non-stress test or a Doppler flow or a BPP. So those are the ones that we would be doing if there was some underlying problem that we're trying to rule out. But your daily assessment of fetal activity are your kick counts. That's the way to know that baby's in there doing okay, is if you're feeling baby move. Yes, this is your amniocentesis. It's a test performed to examine your fetal cells in the amniotic fluid. Some important things to know about an amniocentesis is you should not be doing this on a gestation that's earlier than 15 weeks, right? Because that puts the baby at risk for developmental abnormalities. It can cause hemorrhaging, it can cause fetal demise. So you're waiting until the mom is at least 15 weeks along to be doing any type of invasive testing like that. Okay. I know we went over this one in week 2, and I have a couple of videos on my PowerPoints that kind of go through like what exactly an amniocentesis is and what it looks like if you guys want to check that out too. Our test that we use to screen for Down syndrome is your triple marker, which is going to be blood work that is drawn from mom. Do you guys know what we're specifically looking at to determine if an infant is at high risk for Down syndrome.
Extra chromosome?
We're looking at that. There's also a specific marker that will flag in infants that have a potential to have Down syndrome.
I can't remember the name of it, but I know it's something that like the level of it is lower, right?
Yes, it is your alpha fetoprotein.
Yeah, that's right.
Whenever moms get blood work drawn, so usually the common test that they're doing right now for prenatal gestational testing is your Natura, which is a genetic carrier testing box that kind of looks and see, like, we look at the genetic makeup of mom and we see if she's a carrier of anything kind of crazy. And then one of the things it's testing for is your alpha fetoprotein. So what is the other thing that a increased alpha fetoprotein, if you have a low alpha fetoprotein reading, that is going to be a flag for Down syndrome. But if your AFP is elevated, what are we worried about then?
Is it autism?
So it's actually your neural tube defects.
Oh.
So a low AFP is an indicator of Down syndrome. A high AFP is an indicator for neural tube defects. But this is all going to be seen in that triple marker testing.
This is gonna be stupid, but aren't those like a stupid question? But aren't those the AST? Isn't that in the liver? Like that's part of a liver test.
Oh, you're thinking of AST. I'm saying AFP. Sorry.
Oh,
But yeah, your AST is your liver.
sorry.
No, you're good. That's fine. All right, last one here. Okay, so for screening for ABO compatibility, that is your Coombs test. Your Coombs test is it usually is what we get from like cord blood. Okay. So that is going to be testing for both moms direct Coombs and babies indirect Coombs. So I would definitely know about that ABO compatibility screening. That also kind of goes hand in hand with RhoGAM, but you don't need to really be doing anything super invasive when mom is pregnant. You just need to draw her blood and get her blood type, right? So when are we giving moms RhoGAM? What kind of blood type do they have?
RH negative.
Correct. Yeah. Rh negative blood types, and occasionally we're also going to be doing O blood types because those are the blood types that we're also going to be testing the cord blood for at delivery to see if baby has a high Coombs or a positive Coombs. The other important thing to know about Coombs is if a baby has a positive Coombs result, so like the blood is not compatible, that can increase the infant's risk for developing jaundice. And it's the fetal anemia. I'm not going to be able to say the big word right now because it's not right in front of me. But that's when you're worried about baby having jaundice and having like the yellowing of the skin, the yellowing of the eyes, all that kind of stuff where they're not eating super well. So I would definitely know about your ABO compatibilities and then the Coombs testing. All right, so that is the end of that first game. Let's see what time we're at. So there's one more review that I want to go over with you guys, and it's this exam prep. If you guys have to leave at any point, you're more than welcome to, but I'm going to plan on like, let's do this one. And then at the end of this, I'll let you guys ask questions if there's anything else that you want to go over before we're done. Okay. But this review isn't going to just be on like 1 week. It'll kind of have every single concept from weeks 1 through 3 involved in it. So it'll be a really good review. All right, let's get started. So the answer here is notifying your OB because our normal fetal heart rate, right, is 110 to 160. So this would be abnormal. So anything abnormal, you're going to want to let your doctor know about. Okay. Let's see what else. So you also would want to document the findings. So that's not incorrect, right? You want to be documenting anything that's abnormal and charting that for sure. But your number one, your priority would be letting your OB know so that they can let you know, like give you orders, like whether that's they're going to come to the bedside and assess the patient or whatever it may be. All right. So our three correct answers are allowing for fetal movement, maintaining your body temperature of the fetus. It surrounds and cushions and protects the fetus. The only reason it's not number four is because that provides exchange of nutrients and waste between mother and fetus. That would be like your placenta because it's exchanging nutrients between mom and baby. Okay. Your amniotic fluid isn't really doing anything with mom. It's kind of there mostly for fetal protection. So anything that you see that's between mom and baby is going to be more placenta related. So your placenta is the way the baby gets food and oxygen, and it provides exchange of nutrients and waste between the mother and the fetus. So it's not what is cushioning and protecting the baby. The placenta is adhered to the wall. It's not like surrounding the baby. And then it's not preventing all antibodies and viruses from passing to the baby because there are still some things that baby can get in utero if mom becomes sick or whatever. But that is the main functions of it would be to get food and oxygen and to provide exchange of nutrients and waste. Yep, you guys got it. An informed consent needs to be signed before the procedure. So the other ones are obviously not true, but I want to go over that one, the fever. So if a patient experiences a fever after an amniocentesis, that's something that would be like an emergency because an amniocentesis is an invasive procedure. So anytime that there's like a puncture or an injury, we're worried about infection. So if you're giving your patient discharge instructions and you're telling them, okay, like you need to monitor for fever because that could be a sign or symptom of an infection. So we definitely do not want to see that after an amniocentesis. Yep, so July 26th of 2021 would be correct because if we're using Nagiel's rule, that's subtracting that 3-month period from October and then adding the days to the October 19th. So July 26th. So yeah, definitely no Nagiel's rule because we've already seen it twice in this little review session. So I would assume that's going to be pretty important. So if we're seeing variable decels, we are suspecting that there's a cord being compressed somewhere. Your early decelerations are a normal finding, and they're the ones that mirror your contractions, right? Early decelerations is usually because of head compression, not cord compression. Head compression is just fine. We expect that as the baby is making their way down through the birth canal. Umbilical cord compression is not what we want because that can limit the amount of oxygen that's getting to the baby. Variability on your tracing is a normal finding. That's what we want to see. That's just when the baseline is pretty steady and you have like the motion in the baseline. No big drops or big accelerations. That's just variability, is just the movement of the baseline. A good mnemonic, which I know we went over in class yesterday, but is that veal chop mine. I would definitely know that going into your test because they're like Professor McBride said yesterday, there's not going to be a time where you guys are actively analyzing fetal heart rate tracings, but there might be questions similar to this one of if you are suspecting umbilical cord compression, what is causing that? And that could be, or what are you seeing on the monitor? And that is variable deceleration. So we want to be just documenting this. Accelerations, this episodic is probably what threw you guys off. This just means that it's occasionally. The baby is occasionally having accelerations. Accelerations on our fetal heart rate tracing are a good thing. We want to see those. That kind of goes back to that veal chop mine. Accelerations are okay. We just continue to monitor the patient and we can document our findings. Let's see what other. Yeah, at this point with Excels, if it's good, that's normal. We don't need to tell our providers. And you can reposition the mother and see if the heart rate or anything changes or if the baby starts having more accelerations. But at this point, there's nothing that you really need to do because accelerations are normal and we want to see them. Yes, we want to assess the fetal heart rate baseline. We also are going to want to determine intensity of contractions, but our number one priority is making sure that baseline is normal. And we also are not able to determine if the baby's having decelerations unless we know what the baseline is, right? Like you can't just like put a baby on the monitor and 2 seconds into the tracing and be like, oh my goodness, we're having a late deceleration. You have to be able to know what the fetal heart rate baseline is for at least 2 minutes before you can determine if we're having any abnormalities off of the baseline. So our number one priority anytime a mom is coming into the OB floor is we need to listen to that heart rate. You want to know what baby is doing pretty much right away. So if I have a mom that comes in, pretty much the order of business that I do is as long as she's not telling me she's actively about to push out a baby, I help her into the patient gown, get her in bed, and immediately put that baby on the monitor. That's what we want to know right away. Okay. We can ask the client, like, whenever we're doing the admission history, like, if after we've gotten the patient on the monitor, we've checked her cervix, we've called the provider to tell them that they're here, then we can start asking them the questions like about their history and asking like when they last had intake. But our number one priority is getting that baby on the monitor. We're going to listen on the right side of the mom, right? So going back through our fetal descent and the positioning of the baby, that first letter R is the baby's relation in response in according with the mom. So baby's on the right side of mom. Baby is lined up with the right side of mom. Then we're looking at like the O is their occiput. So the baby's head is down. And then P is posterior, right? So definitely knowing what those letters are. And then if you guys reference back to the slide that we had, the PowerPoint that we had yesterday, I had a couple pictures in there that were from your textbook of fetal station, attitude, lie, position, all that good stuff. But Leopold maneuvers, remember, is putting your hands on the mom's belly to kind of feel where the baby is at in the uterus. And then you're going to be able to determine, okay, where's the baby's back, right? And then you can listen with the Doppler on that side. Yep, so normal amniotic fluid is clear, colorless, and then it can have those little white specks. The little white specks would be like vernix from the baby, right? Just like normal stuff that's floating around in the amniotic fluid. Um, we do not want to see any cloudy, green, dark, smelly amniotic fluid because that can either be a sign of choreo, like infection, or meconium from baby um, in utero.
Question on this one.
Yeah.
So I was doing my NCLEX questions this week and the I kept getting it wrong because it kept saying straw-like colored. Is that
So you can have a little bit of that with amniotic fluid. That's really tricky. I don't like that they asked that they did said that. Um, but yeah, it can be a little bit straw, like have like a light color to it. Um, we just don't want to see anything that's like super dark. Like this dark amber would be like it could be sign of infection. Um, so yeah, that is kind of tricky though with the NCLEX stuff. So we want to change the client's position. Stopping the Pitocin infusion is not incorrect, because I know yesterday whenever I was in lecture, I said that if you're doing any type of intervention, you should be stopping your pit infusion. With this one, I think it's mostly asking along the lines of like the veal chop mine mnemonic of if you're having variable decelerations, what does that mean is happening, which would be your umbilical cord compression. So what do we want to do? We want to get pressure off of that umbilical cord. And the best way to get pressure off of the umbilical cord would be to change your patient's position, either to that lateral lying side position or on your hands and knees. So we see moms come in with back pain if that baby is posterior. Okay. If you hear OP babies, that is a posterior baby, and they're putting a lot of pressure on the mom's lower back. That is kind of what we were talking about, like prolonged labor, irregular contraction patterns, ineffective contractions, that can be caused by a posterior baby. But yeah, with back pain, if a patient's telling you my back hurts so bad, we need to check because that baby's probably OP. So when looking at a strip, we're seeing if how baby's oxygenation is. Okay. There are some ways that you can see how labor is progressing by looking at a strip or a fetal monitor, but that's not until you've like done bedside nursing for labor and delivery nursing for a long time. You can look at a strip and be like, oh, we're having some variable decels. That must mean that this is what's happening with her labor. Um, but for the purpose of this class, one of the biggest things that we're determining from a fetal heart rate tracing is how baby is being oxygenated, right? If they're having decelerations, it most likely means that they're not being oxygenated very well. And that can be from a lot of reasons, for a lot of reasons. But that is what we're looking at our fetal tracing for. Yeah, we want to perform a pelvic exam. So one of the key things that I want you guys to look at this question is when it says multiparous, that means that this is not this woman's first baby. And then she's telling you that she feels like she needs to poop. She's probably just having an excessive amount of pressure from wherever the baby's head is in the birth canal. So if you have a mom, this is like her fourth baby, and she's telling you that she needs to poop, I'm not gonna let her get up and go to use the bathroom. If we do a pelvic exam and she's still only like 6 centimeters, then yeah, if she, as long as she doesn't have an epidural, we can help her up and help her go to the bathroom. But or help her to the bedpan. But the first thing I would do is check her cervix to make sure that this baby is about to come out. So, fetal presentation is the fetal body part that enters the maternal pelvis first. Okay. Um, that is more of like a definition thing. So, what I would do for you guys to kind of like get a little bit more familiar with this is yesterday on our PowerPoint, whenever I was talking about the factors that affect labor, go through those definitions and look through and if it, and you can also look in your textbook, they go into it in a little bit more detail in your text. Because you want to know the difference between fetal presentation, fetal lie, fetal attitude, fetal position, all of those things mean a little bit different. So I would definitely know the differences between those definitions. So the most common thing we see with epidurals is hypotension. Uh, a postpartum headache, that would be like if they had like a spinal tap, like if the epidural was placed in correctly and then it like went up and is causing them problems and they're having headaches. That's not common. We don't see that actually very often at all, but it can happen. The most common and harmful maternal complication is hypotension. So, what are your nursing interventions if a mom becomes hypotensive with an epidural?
Um,
We would want to reposition them. So either lay them on their left side or lay them in as like
Mine is frozen.
mine is.
No, mine is stuck on the hypotension one.
Oh, I haven't changed it yet. But if the mom becomes hypotensive, we want to just like lay them back. We want to give them a fluid bolus. Um, we want to call the anesthesia provider to the bedside so they can administer ephedrine to bring their blood pressure up. And then we want to apply oxygen. Okay. So we have two arteries and one vein. Okay, so that definitely know that one for the test. Yep, so 150 beats per minute lies within that 110 and 160 range. So that would be a normal fetal heart rate. Yep, this would be a softening of the cervix. So definitely know your Goodell sign, your Chadwick sign, your Murphy sign, McDonald sign. Those ones definitely know the difference between all of those. Yep, so quickening is the fetal movement that's felt by mom. The irregular painless contractions that occur throughout pregnancy are Braxton Hicks. That's what those are. So yeah, know the differences in these definitions here. Yep, so probable signs of pregnancy are your uterine enlargement, your Chadwick's, and your Braxton Hicks contractions. Um, the outline of the fetus in an ultrasound is the definitive one, the definitive sign of pregnancy. Probable signs of pregnancy are the ones that are like, yes, that probably does mean that you're pregnant, but the only way that we can 100% verify pregnancy would be visualizing or auscultating the fetus via ultrasound or a Doppler. Okay. I know that we went over those kind of probable signs of pregnancy, the three different categories of signs of pregnancy in week 2. So I would review those to know like what's a probable sign of pregnancy versus possible versus like a definitive sign. We want this mom, we want to be telling them things to do to see if these contractions go away. Okay. So Braxton Hicks contractions are those irregular occurring contractions that can happen like later on in your pregnancy, throughout pregnancy, sometimes depending on the mom. So as nurses, we want to tell them like things that they can do to see if they're going to go away. So walking around a little bit until they stop is something that we can recommend. Um, Timing them, um, we would tell them to time the contractions if they were like extremely painful and occurring regularly. If they're irregular, we still want to see if they're going to just subside on their own. So giving the mom things to do to try and get those to go away. If she does walk around and she's been walking around for an hour or so and they're still happening and they're becoming more regular and more painful, then we're going to want her to time them so that we can know if she's like starting her labor. Yes, so maternal and fetal blood are never exchanged. That's correct. Last one here. Yep, the number of times that a mom has been pregnant is her gravida. Okay, regardless of the outcome of the pregnancy, the total number of pregnancies would be her gravida. So that would be the G in your mnemonic. Okay. So before we end our review session, is there anything else that you guys have questions on or things that I can point you in the direction of? How are we feeling? Okay, so if anyone wants to stay over a little bit to meet with me, I probably have another like 10-15 minutes. But if nobody else has any other questions, you guys are good to go. Definitely reach out if you have questions or anything about the exam, but just like definitely study those points that we went over in the review session, and I think you guys will be fine.
I have a question.
Yeah.
Can you go over the GP, that mnemonic thing again really quick?
Yeah, let me get my PowerPoint up.
Sorry.
Oh, that's okay.
Thank you for the review.
You're welcome. Let me see where it's at. Hold on.
While you're looking for it, can we still use the game for this exam to study?
The Kahoot?
Yes.
Yeah, I think I can try and pull it up. I don't know if I'm going to be able to do that, which I do have this mnemonic up. So let me just show you guys this really quick. All right, so here's the GTPL. So your G is your total number of pregnancies. Your T are the amount of term deliveries that you've had after 37 weeks, right? Because we've determined that anything over 37 weeks would be considered term. Your P's are your preterm deliveries before 37 weeks, but are after 20 weeks, right? So it's still it could still be a viable fetus. And then your A is your abortions, spontaneous or terminated before 20 weeks. And then your L are your living children. I can try and get like a quick little practice one, and we can just like kind of walk through a practice one here together. Let me see. All right, so I just kind of wrote one up here. So we'll go through it kind of like step by step. Okay. So a woman comes in for delivery of her fifth, let me see, of her third, actually, of her third infant. She delivered her fourth at 38 weeks. Her third pregnancy was a miscarriage at 12 weeks. Her second pregnancy was a delivery at 35 weeks. And her first pregnancy was a miscarriage at 6 weeks. Okay, so let's start with our G's. How many times has this lady been pregnant? She's had 5 pregnancies because she's pregnant now. Yeah. So this is her 5th pregnancy. So she's been pregnant now a total of 5 times. So she delivered her 4th child at 38 weeks. So where would that fall under?
Under the T.
Yep, so you have 1 under T right now. Her 3rd pregnancy was a miscarriage at 12 weeks. So that would go
A.
Yep, that would go under your A. Her second was a delivery at 35 weeks. So where would that be?
Under P.
Yep, so that would be your P. And then her first pregnancy was a miscarriage at 6. So that would go where?
Under the A.
Yep, and then how many living children does she currently have right now?
4. 3. No?
She has 2 because her third one she's
Because
hasn't
2
delivered.
abortions. She's
So
pregnant, but hasn't had it. So
So
3.
you don't count the one she's pregnant with as a living child until that baby is born.
Correct.
Okay.
Yeah, so right now the one that she's pregnant with, the only classification that it's under is G because we haven't
Okay.
delivered it, we haven't had, we haven't had any outcome. So this is just a pregnancy. Okay, so her G's would be 5, her T would be 1, her P would be 1, her A would be 2, her living would be 2.
Oh,
Okay.
Okay.
Thank you.
Yeah, does that help a little bit?
100%.
Yes.
Okay. It is a little bit confusing of a concept sometimes, but whenever you I also think whenever you're doing it with Kahoot, like it's moving really quickly. If you have time to kind of think about it and look at it written out in front of you, I think that'll be a little bit
Yeah,
easier.
those kind of quizzes for me, timed, are not good.
Yeah, I don't blame
I'm
you.
like still reading the question 3 times and you guys already answered.
It's like 20 seconds or nothing. Like it's just not fair.
Me at least.
I
But
have a question.
yeah,
Um, a lot of us joined. Sorry, I hear myself. A lot of us joined Dr. Roberts yesterday, and she was gonna send out the Zoom recording to me for me to send to the Pensacola students who's in your class. Do you know her email so I could email her to remind her of the note she was gonna send?
Dr. Roberts, I think
Yes, ma'am.
let me pull it up.
Because I can't find it.
Is it just for exam review?
She was gonna send like all of her study material.
Oh, okay. Yeah, I have her here. It is E. Roberts at fortiscollege.edu.
Roberts at fortiscollege.edu.
Yep.
Perfect.
And then I have one more question for you.
Yeah.
For our exam review, I saw the PowerPoint that you sent out, and it's like 93 slides. Do you ever do like a recorded review? I just like to I like to listen to an audio and type my own notes.
I don't think I've released a PowerPoint, like a review. I don't think that was my PowerPoint. I don't think.
There was one in there that was like
Dr.
90.
Roberts. It's Dr. Roberts, I think, and that's who I'm trying to email.
Okay.
Yeah, so this is my first semester with Fortis, so I haven't really done many reviews. This is my first review session. So in the future, I plan on doing another more of these. Um, I haven't really thought about a PowerPoint or doing anything like that yet, just because I don't really have anything put together for it. But
Okay.
in the future, for future exams, I might hold more than one of these review sessions, just depending on what people need and how people are feeling about it. But yeah, I think it's probably Dr. Roberts' material that you're seeing that has the really big PowerPoint.
And that would be like if we study Dr. Roberts, would that be beneficial for our test?
Every single professor is teaching the same exact material. Okay. So the stuff that you learn in my class, Dr. Roberts is going to be covering in her reviews. The stuff that I'm covering in my review is going to be in Professor McBride's class. So we're all on the same curriculum. So any of the review sessions that you guys attend, any review material you guys go over is going to be beneficial for your exam. Yeah.
Okay, because there was some, I was gonna have you look at some of, well, like elaborate on some of the notes that she was taking yesterday, just to make sure that that is correct, I guess, in a sense. I think it was mainly during week 1, just because I don't remember going over a lot of it. Like assimilation, acculturation, is that all stuff that we need to know?
Yeah, I would say that anything that is in her review sessions, my PowerPoints, your textbook, anything is fair game, really. So I would definitely take some time knowing. I mean, that sounds more like definition based stuff. So, running through those like cultural competencies in your presentations, I think would be beneficial. Yeah.
Okay.
Yeah, but we all teach the same material and our exams are all relatively the same. We do like kind of go through different questions and pick and choose what we want to include. But if you're studying with Dr. Roberts' material, it should be just fine to prepare for like the exam in our class.
Okay.
Someone another game.
So I don't know if I have time right now to do another game or review session, just like review game. I'm gonna reach out to Professor McBride. She worked night shift last night, so she might still be sleeping. Um, and see if I can send her those Kahoots, send you guys those Kahoots, or I'll just like copy and paste the those to like the review session that I post because I'm gonna post this recording in Canvas so that you guys have it. Okay.
Thank you.
Yeah, all right, guys. Good luck with everything, and I will see you next week.
Thank you.
Okay.